I have a question. I have a concern. I was talking with my doctor, and there's a lack of energy. I don't have much energy, and I have extreme fatigue. So what could be done? And I was told to ask you the question. So what about this hormone therapy? It seems that you cannot give it before. It seems that there is a lack of hormones. Well, it's been well established in Europe, but here in Canada, it's not been acknowledged yet. So do you have something to say about this? Well, side effects of hormonal therapies and all of these substances, whether it's the abiraterone, anti-androgens, all of these have these types of side effects such as extreme fatigue by cutting the androgens. These are the types of side effects. They have different types of side effects, of course. Now, it's difficult to see what you can do. The first thing is to change your activities, trying to remain quite active in terms of physical condition despite your fatigue that you feel. This is contrary to reason. You are more tired, but you're asking your body to do more activities. But this is the first thing to do. Trying some methods of changing your habits by at least doing 3 times of exercise during the week. Now, once you've done this, after that you might consider also to do some hormonal therapy depending on the stage of the disease. And we're not getting into the details here, but you might also stop hormonal therapy for a period of time. This is called intermittent hormonal therapy. So you might give it for a year, then stop, and then allow testosterone to go up again, and then give it again. So normally that type of intermittent hormonal therapy is given to patients that don't have any metastasis, right? That don't have any metastasis, and it's been shown as being totally safe to do that. So this is yet another option. Have some periods of rest when you can recuperate. Now, if the stage of the disease is more advanced, you might use some different drugs, and you might use you might change the molecule. Sometimes some molecules are associated with more fatigue or less, depending on the symptoms and also of the answer of the disease. You might decide to change the molecule, the drug. But once again, sometimes you need to change and you need to discuss with the patient, because if you have a fatigue level which is average and you have a very good answer for your cancer and it is totally controlled, then you might play a little bit Russian roulette if you make changes, and then you might have the progression of the disease. So all of this needs to be considered. It's not an easy answer, it's not an easy situation, because you have the progression of a disease, and when you have metastasis, it's going to create fatigue. The treatment is going to add on top of that. So you need to attack that type of fatigue by different ways, different actions, in order to optimize the quality of life of the patient. So PSA is the only indicator, so there's nothing else to do. During the months and years, you just monitor PSA, and if the doctor says things are going well, you take this for granted, but there's nothing else to monitor. Well, in fact, you have the answer to your question. The first thing to do is that you're going to treat a patient and not just treat the PSA. So if you have pain, is there any side effect of your treatment? You ask the patient, and in parallel, you're going to monitor PSA to monitor the disease. At these stages of prostate cancer sensitive to castration, so when you go through all of these stages, all of these lines of treatment, allopurinol, docetaxel, and radium, you're going to use more and more imaging, because there are some cancers that are going to secrete less PSA. Sometimes you have to use other tools to monitor cancer. But apart from that, the tolerance of treatment of the patient is also of paramount importance. Good evening. Somebody that has been a removal of the prostate. So do you base yourself on the analysis of this prostate which was removed in order to give a result before PSA, or do you analyze it? So do you have sufficient data in order to know if there might be some cancer cells. Yes, absolutely. So we have the stratification, as I say, which is assessing the cancer. Is this an aggressive type of cancer with the Gleason score, Gleason total? So this is after surgery. Then it's precise. Then you have all of the data which allows you to say if the patient might have a recurrence of a cancer. So if there are lymph nodes monitored, then you're going to know if the cancer has some cancer outside of the prostate area, and so on and so forth. So all of you that you've mentioned is true. You can better predict the recurrence. But apart from that, PSA is a little bit our trigger of treatment. If PSA is at 0 after a radical prostatectomy, then you are not going to do any action. You won't do anything. So you have some idea, but then the PSA will become our best measure. But this pathology, you want to see if there were some in the lymph node. If the Gleason level was high, then this gives you the probability of cancer occurrence outside of the prostatic area. If there was radiation therapy, if the PSA might increase, Gleason 9, and so on and so forth. So the chances of answering of a response are lowest. You can use some mathematical equations, monograms that are going to give us indications about the best treatment possible. But in the majority of cases, patients are still going to take that chance because they want to be cured. Sometimes the chances of cure is quite low, but you can use all of these options as well. Thank you. A few years ago, I underwent a vasectomy. Is it possible that there are some cancer cells in my testes? No. It's never been reported in studies. Okay, thank you. We've just got one question, a complex question here. Here we're talking about a man that is 65 years old that just got a diagnosis, and the PSA level is 15, Gleason score is 9. Here's the question. Prostatectomy was not envisaged, but he wanted to know more about the radiation therapy or chemotherapy. He had a hormonal therapy, a chemotherapy, and now he's starting his radiation therapy next week. So he wanted to have more information about chemotherapy, and he wanted to know if he was on a good, if there are good chances of controlling his condition. It's difficult with these types of informations to give a clear answer. Here we're talking about a prostate cancer which has high risks level. Gleason has a maximum score of 10. So Gleason score maximum is 10. So it's very important to have some type of therapy which is aggressive. And right now, there are two ways to treat aggressively the prostate cancer, and rarely it's going to be one single therapy. So you always go to the same concept, radical prostatectomy, and you know that with radical prostatectomy there are high chances of needing hormonal therapy as well, and also radiation therapy. So more and more this is accepted, and there is a trimodal type of therapy, and each one is going to reinforce the other. The radical prostatectomy is going to remove cancer and lymph nodes, and then if there are some cells left, you're going to use radiation therapy. Studies of 2017 show that if you also add hormonal therapy, you also increase the efficiency. So this is the most aggressive type of treatment. You can also use a hormonal therapy and also chemotherapy or radium therapy. This is yet another option which can be envisaged and which is acknowledged. Then it's a matter of the choice of the patient, what is their preference, and also what are going to be the side effects of each of these therapies. But of course, this is a cancer that should be taken seriously, and you need to use all the tools available to control that type of cancer. Thank you. Right now, There are some pharma companies that want to sell us some drugs, always preventive drugs. So regarding prostate cancer, is there any research which is being done right now in order to look at some type of medication that might prevent or slow down efficiently prostate cancer? Does that exist? Is there any research about that in order to prevent, to use prevention of cancer, of that type of cancer? Yeah. There are many studies which have addressed this during the years 2000. There were lots of focus on prevention of prostate cancer. Some studies were made for prevention through food, the diet. There's a study called SELECT. They looked at selenium and all kinds of diet changes. So they've done a complete study with all of the known doses, not just with natural products. And that study, the results of that study were quite negative. It's difficult to prevent the appearance of prostate cancer. Other studies were also done. They were using real medication. You might know the Prostate, which is a finasteride, or the other, it's dutasteride. Prostate drug is the same substance which is used in order not to lose your hair. This reduces the synthesis of androgens in prostate. So they give either placebo or the Prostate or dutasteride, and they looked at the diagnosis of prostate cancer, and the answer is yes, 23% less prostate cancer. So now, where these molecules did not continue afterwards is if you have low risk level prostate cancer, then you're not going to intervene. You cannot do the diagnose, and you will just monitor them. So this study, the company has not been able to approve this drug. And so there are so many other studies. This really is something that was looked into. However, we have not found yet our medical drug for prostate cancer prevention. And this cancer, which is going to lead to a death, and not just this little cancer. And this is the problem with the avocat and the prostate. So no real success with dangerous cancers. Okay, I had a prostate surgery, and after this surgery, they made the assessment of the prostate, and my Gleason was at 6. So, yes, I would have been a subject here. Now, concerning all of these side effects of surgery, I'd like to know if my chances of survival are higher because I had a surgery with a Gleason of 6, or rather than having waited for longer. Well, in fact, it's quite reassuring. So active monitoring with biopsies, you monitor the PSA and so on and so forth. So with Gleason 7, as you had, where you recommend the intervention because there's some potential there, but you have the opposite. You went from 7 to 6, right? Which is some good news. This means that from your body, somebody that going from 7 to 6, you have removed cancer which didn't have much potential. You have removed it, and you know that it's not hidden elsewhere, 8 or 9 or elsewhere, because it's been analyzed. It's a bit like the question of the gentleman. It was analyzed and it's not aggressive. So the chance that you are cured are very good. They are excellent. Some studies have included 1,000 cases, and no patient had developed metastasis elsewhere, because with this type of cancer, with these results, if you can analyze it and make sure that it's only this one, there is very low chance that it might go elsewhere. We think that today Gleason 6 is some type of cancer. We wonder if we should not change the name of that type of cancer as being, give it another name, because its potential of causing the death of the patient is very, very low. Long answer, just to answer, yes, this is a good news. And my urologist told me, he showed me a table called Capra-S. So you haven't talked about it, right? No. Again, is this still valid? Yes. This is one of the best tools that exist to do the forecast of the survival rate using the microscope analysis of the pathologist. But once again, there's an analogy with the question of the gentleman. If there's no PSA recurrence, you won't do things very much differently. You wait and monitor PSA before you start any other treatment. Another question, you have been talking about these cancer cells that are using testosterone. What about the andropause treatment by taking testosterone after surgery? Well, in fact, my opinion is quite clear about this. I hope that I will not be too much biased. People that need an androgen replacement, if you are in the andropause, if you are losing muscles and memories, by looking at the testosterone, you see that it's quite low. There's no problem to give testosterone again to a patient if you had a cancer and if the PSA is at 0, if you have normal testosterone levels. So you're going to answer to the symptoms of the patient, and you are going to have the patient which is like anybody else. Testosterone is like the food or the fuel of prostate cancer, but it doesn't create that cancer, different from gasoline for a car. So if you give testosterone, so if there is a recurrence, testosterone did not create the recurrence, but it allowed you to do the diagnosis. Without testosterone, cancer will adapt, and we think that it might become even more aggressive, and when it will recur, then it might be more aggressive, because with testosterone it became resistant to castration. This is quite speculative, but I don't see any problem with that. This is my answer. Yes. So we have a man that is 63 years old. He had a prostatectomy after 2 years of hormone therapy with also radiation therapy, and the isotopic bone scan doesn't show any metastasis. The PSA was going up again recently, and the question is, how can you address this situation with my radiologist or radio-oncologist? So this is somebody that had a first-line treatment, radical prostatectomy, followed by hormone therapy and radiation therapy. Yes. And now, is he under a hormone therapy? He doesn't say. This is an important factor. As we've seen, this totally changes our different tools that you might use, resistant to castration, more sensitive to castration. So it's quite difficult for me to, so there's no hormone therapy after the radiation therapy he stopped. He also got his isotopic bone scan. It seemed okay, and then slowly the PSA level is going up 0.06. He just wants to see how he can address this. 0.06 is quite low. Don't be concerned of 0.06. Here we are talking about this slide, which shows that you need a period of time of observation without treatment when a PSA after local treatment, surgery, or radiation therapy, when PSA is going up. For some cancers, you might wait up to 9 years before seeing some metastasis. So there's nothing which we shouldn't hurry. We need to look at the dynamic of change of PSA, and if you reach a threshold, then there are some recommendations of the European Urology Association. So then you might monitor if there are metastases, and then depending of the results, you might wait or start some intermittent hormone therapy. So right now we are at the beginning of the detection of PSA. Maybe that it will go down at the next monitoring. So at this stage, this means you will not do anything about it. You just monitor. Good day. In June 2016, I had a radium therapy. PSA was 8.6. After a few months, my PSA went down to 2, and in December I had a surprise. I had 32. And of course, my oncologist wanted to do some more tests, and I was under hormone therapy in last April. Is it too late to talk about chemotherapy? Again, I don't want to give some advice for personal cases, but regarding hormone therapy, I don't know yet the indications. If I was referring to this 13 months, but you need to have some metastasis, bone metastasis. I have some of them in the lymph nodes. Okay, so this is more, this is a debate. So here we are entering into the subjectivity. Two studies have shown the benefit of chemotherapy for prostate cancer sensitive to castration. One study would include patients with only lymph nodes. It's very similar to your situation, and there was a survival benefit for these patients. There was some benefit if you take all of these patients with metastasis, lymph nodes, and bones, and you would give chemotherapy. There was a survival benefit. Now, the other study that I've shown also with those curves, this is yet another study, and this was mostly for patients with metastasis in bones, a lot of them, what we call a high level of bone metastasis, and they would benefit compared to those that had a low volume of metastasis. So you would be less of a candidate here. But what we recommend is to start chemotherapy during the first 6 months. And so if somebody is in the situation when you learn that chemotherapy might be an option, then after 6 months, and even a little bit more, you might discuss with your oncologist, even though you need to look at the criteria. This might be beneficial for the patient, possibly. Second question, the side effects of the hormone therapy in my case, because I'm taking some corticosteroids. Now, if you add some chemotherapy, are you increasing the side effects? Well, chemotherapy, I didn't get into the details, but with your questions, I see that I didn't cover it all. I could have talked for 2 hours easily, but chemotherapy is 6 cycles of 3 weeks. So it's not like hormone therapy. Yes, chemotherapy might give some fatigue and other blood side effects. This might create some anemia, and there are some side effects. But this is the price to pay in order to have a longer survival rate on the long term. Now, if you look at some of these drugs, Viagra, enzalutamide, radium, cabazitaxel, these are benefits of 2-3 months more for the complete group of patients, complete cohort. But now with chemotherapy, with hormones, we're talking about an extension of 13 months. This is a very big benefit. You don't see that very often in systemic therapies for cancers with metastasis, all types of cancers included. So it's worthwhile to consider and to accept these side effects for these 6 cycles if you are a candidate. Good evening. I wanted to talk about radiation therapy. We know that radiation therapy kills good and bad cells. I'd like to know, doctor, what are, generally speaking, the side effects of radiation therapy? Rescue radiation therapy with a radical prostatectomy, a recurrence, and then you're going to give some radiation therapy afterwards. Yes, this is why I didn't address the side effects, and I've shown you the anatomy. What happens is that in your pelvis, you have the rectum, you have the urethra, and you have the so you are going to irradiate all of these organs in that location. So what you might have is some inflammation of the you're going to have a bladder inflammation. You are going to have a bladder that contracts more often because the good cells of the muscle are going to die. It is going to do some type of scarring, and the bladder is not going to be like a beautiful bladder. This might create some urinary side effects. It might create some diarrhea and also some bleeding in the rectum. And these are mostly the side effects in the surrounding organs as side effects. Now, in most of the cases, these secondary effects, side effects, are of a low up to moderate level. However, there are some 5 up to 7% of patients, 1 patient out of 20, where the side effects might be more severe. requiring sometimes hospitalization, and this might really reduce your quality of life. So it's always striking the right balance between about the therapy. So what you have in your mind is, the question is, what is the risk? Even though I have only 5% of chances of having a response and I have a chance of curing, I'd like to have the best chances of curing, right? So we're talking about these patients that are going to have more important side effects, 7%, 5% bleeding in the bladder or in the rectum, or some more other side effects. Now, regarding the bladder, is this incontinence, which is a side effect? No. Most often, it might be an hyperactive bladder, which is the side effect. It could also create, indeed, some incontinence if there is some scarring. You might have some type of pipe problem if the pipe is not working very well. And so what you will see most often is some irritation, which means that you will go to the toilet more often, and sometimes you will have a reduction of the capacity of the bladder. The bladder is like a balloon, and if you irradiate it, this scar will not be able to expand as much as a balloon, and therefore you might need to go more often to the bathroom. So this is mostly a hyperactive bladder, which is the side effect. Thank you. Dr. Pouliot, we have a question about radium-223. Two questions. The first one is, I'd like to know if I can do some exercises like walking in the mountains, trekking, to have a higher risk of fracture. The risk of fracture is lesser if you are treated rather than not treated. However, it is a matter of the status of the disease will justify the use of radium, and this is going to establish the risk of fracture. If you have metastasis in the vertebra, if you have big metastasis in long bones, which are a support of your weight, then there's going to be some risk of fracture because of the disease itself. Radium doesn't increase the risk of fracture. It's mostly the disease itself which creates the risk of fracture. It's quite exceptional that we are going to tell a patient to be careful and not to do exercise. You just need to be careful and use your good judgment. We talked about bone complications at the end of this conference today, and what's important to do is to remain active in order to stimulate bone formation and reduce osteoporosis when you have hormone therapy. So I really encourage to continue doing some exercise, but be cautious. Use your good judgment. Don't try to set records. There are some locations in your bones which might be a little bit weaker, but be careful. That's it. Thank you. The second question, when you look at this graph and you look at the position of radium in that graph, is there any other option afterwards? Well, in fact, is it used only as a last recourse? It's often used as a last recourse, but there really is a will more and more to use it earlier in the stage of the disease. The indications are a patient with pain. Of course, this is an advanced stage of the disease most of the time. Then you also have some type of bone disease. And after chemotherapy, or if you're not eligible to chemotherapy, sometimes radium was administered very late as a tool. But now they try to incorporate it a little bit earlier in the continuum of therapies. But once again, as a doctor, you have to address the conditions of reimbursement. These molecules are very expensive. Radium, extended, and other drugs. So our governments do not give us that option. They do not give us the possibility to use them. The criteria are very strict, and criteria of radium are mostly at the latest stages of the disease. You might want to use them earlier during the continuum of disease, but sometimes you cannot reimburse them. And also the design of studies, well, you need to respect the same conditions as the ones that were used in studies that have shown that it would increase the survival rate. Good evening. I have a question. I have some beliefs, maybe I'm wrong, about certain types of cancers or the majority of cancers. Sometimes we say that after 5 years you are cured. If you have PSA, you're never cured, right? You know what I mean? Your PSA, can it go up again after 5 years? Or is this like a false belief that I have? Well, the probability that it will recur late are lesser and lesser. So these more strong cancers, metastases during the first line of treatment, surgery, this will come back after 3 years, usually. So after 5 years, there is still some risk, some late risk, but the probabilities are going down. I'm talking of after surgery and after a radiotherapy. This rescue radiotherapy. Well, it always depends of the modality of your therapies. I haven't focused much on this when I did my conference. After radiation therapy, there is some prostatic tissue, so APS will not go down to 0. The presence of some APS, which is stable and detectable after a radiation therapy, 5 years after the radiation therapy, this is like a disease which is controlled, which is not evolving. Therefore, you might talk about a potential cured disease. After surgery, APS is 0. It's 0. After 5 years, the chances of recurrence are quite low. You need to monitor it after 10 years, but it's very, very low. Chances that it will come back are very low. After a surgery, you have some detectable APS. It's stable, but you should not worry. One of the important messages here, which is important, following studies, you need to have 9 years before you have the occurrence of metastasis. You might be in that period. You have this detectable period of time. So if there is some increase, you cannot talk about a cure, right? Even though it's quite low. If the APS is quite stable and at levels under 0.2, then it's possibly some benign tissue. And the counter always starts at 0 again after every treatment. Yes. Dr. Pouliot, I am under hormone therapy. I get injections every 3 months. It seems that after the second and third, it's as if there is some cumulative side effects. It's as if I was able to manage these side effects at the first injection. It seems that now they get worse at the second and third injections. Is there some cumulative effect when you get several injections for hormone therapy that might give some bigger side effects? It depends what type of side effects you're talking about. These side effects in terms of feeling hot, fatigue, I don't have the notion that there is some cumulative side effects. I don't have this memory of patients that have reported this type of cumulative effects. However, feeling weak, some muscular atrophy, yes, the longer you are under hormone therapy, the more your muscle strength is going to progressively go down, and there's going to be some cumulative effect there. And also you might gain some weight. So again, you have to remain active, as I've said before. You are not going to have more muscle under hormone therapy, but you need to keep healthy, you need to remain active, and you need to prevent fatigue, and you don't want to be too weak. Therefore, you need to be active. Good evening. Here I have 3 items which are of general interest for men which are attending, and These are questions I've asked to my doctor, but I would like also to get your opinion. Now, the first one is the decrease of libido. Libido. Second, the second one is, so first one is reduction of the sexual drive. The other one is erectile dysfunction. And the third one is Viagra. So in what type of context? Well, in the context, the sexual drive, is this going to come back with time, or can you say that you just should forget about it in terms of sexual drive? You're talking about a patient under hormone therapy, so the impact of hormone therapy on sexual drive, erectile function, and Viagra. You want to know if Viagra might be a solution. Yeah, so regarding the sexual drive, erectile function, well, it's quite normal before you start. If you stop the hormone therapy, there's going to be some progressive rehabilitation afterwards, which means that this might come along with the testosterone going up. Your third item, which is the use of Cialis, Viagra types of molecules and these types of drugs in order to increase the erectile function. Well, normally speaking, these molecules don't have any side effect on the sexual drive, only on the erectile function. So I would say that if the sexual drive comes back and if the erectile function comes back, but it's not satisfying enough, you might use some molecules that are going to increase the quality of these erectile functions, such as Viagra and others. Did I answer your question? So the short answer is that yes, it's going to recuperate after you end this hormone therapy. So is this good or bad? Is there any other type of drugs which are better? There's no one drug better than another. There are different formulas, different durations of side effects or effects. There are some medications that are going to improve the erection. If there is some castration, this is going to greatly reduce the erectile function, of course. So if you, so this is something against the patient, but sexual drive is the basics. If you have some sexual drive, then you look at this erectile function, and then if you have some erectile function, is it satisfying or not? Then you might use Viagra or Cialis and other drugs that you might inject into the penis, for instance. So you need to discuss this with your urologist, or if you face that type of challenge, you might discuss several options. There's not just one option. And what about Prostate Canada in Toronto? Do they play any role in that? Can they play any role should I get in touch with them? Yes, absolutely. There are two main organizations that I refer all the time. Procure, with all of the informations that they disseminate. They are quite proactive and they are in close proximity with patients across Canada. And then Prostate Canada, which is another interesting resource. So if sometimes there's a lack of information, you might visit the Prostate Cancer Canada website, and this might give you some additional information. After a radical surgery, I was told that the effect of the biopsy can be one of the causes of a recurrence, which means that after there is a biopsy which is made, there might be at the end of these injections, when you retract the needle, some cells might go out of the prostate and might implant elsewhere, and this might create some recurrence. Well, it's not a concept which is accepted right now, this notion of biopsy being a cause of dissemination of prostate cancer. Now, what we've observed, rather, is that yes, there are some biopsies. If you have a patient with cancer, there might be some cells of the prostate that are going to be in the bloodstream, and Some studies have shown that this would increase some of these cells, but the cancer, when we're talking about the Gleason score, cancer itself has already the potential to go elsewhere. It's not biopsy which is going to create that. So it's not a concept. I'm not saying that it's not possible, but no serious study has shown that in the literature. That's what I'm saying. Okay, thank you. Yes, doctor. I've had some issues of hypertrophy of the prostate, and I took some medication for years. Then I had a resection of the prostate, and when I had my cancer, I didn't prevent the cancer, but so when I had my cancer, I met a specialist and I had the choice between surgery and radiation therapy, and my radio-oncologist told me that I was not eligible to radiation therapy because I had a resection of prostate. So what's the relationship between both? Well, it always depends on the type of radiation therapy you want to give. There is external radiation therapy. I think that you could be eligible to that, but there's also this radiation therapy with some implants in the prostate, and this we don't recommend to the patients that had some resection. So these are the technical factors that will tell you of the success of some radiation therapies, depending on the type of radiation therapy. I am not an oncologist myself, so but there are some factors. If somebody has a large prostate and there are different symptoms, you might increase these symptoms. So possibly that surgery will be recommended rather. You don't want to, so there are some nuances that you need to know, and you need to discuss among specialists in order to choose the right therapy. Any other questions? If not, well, thank you, Dr. Pouliot. We are going to conclude our conference. Thank you very much. So I am extremely glad we took more than 30 minutes for this Q&A session, and I think that it was a good decision. There are no other questions so far. All of them were asked. So Dr. Pouliot, I've got very positive comments. It seems that your answers rather, are quite clear. Your explanations were quite clear as well. And some people said also that they never had that type of discussion with their own doctors. So it seems that you've answered to many concerns. And I think that this conference is something which is very appreciated by many and which is something to be watched. As you know, all of our conferences are available on our YouTube channel. And so once a patient gets a diagnosis, they can visit our YouTube chain, and they can be referred also by the nurses. We have our YouTube channel. Now, before we exit, and before you exit this building, I would really appreciate that you answer to our form. We have a little survey. We know that we can better answer your questions. If you have some suggestions, some questions, please write them down. This is how we can improve our conferences. This is how we can organize our next conferences. It's through your feedback. So please take 2 minutes to answer to our little questionnaire. Now, if you have the opportunity to wear this little tie, Again, this bow tie is available on our website, so if you have the opportunity to wear this bow tie, this is for our campaign, and all of the funds will be to improve our work. Once again, thank you so much, everyone, for your attendance. Thank you to all the participants on the internet. This conference will be available on our YouTube channel during the next week. If you have any questions, get in touch with us, and our nurses will be able to answer to your questions. Thank you so much, Dr. Pouliot. Once again, thank you for this great conference. Thank you.